Let's be clear, the importance of eye health cannot be understated. By taking care of your eyes, you will reduce the odds of blindness and vision loss. Seeing through a clean lens, the importance of good eye health. Tonight, on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host tonight, Dr. Debra Johnston, and tonight we're going to be discussing eye health. Your eyes are an essential part of your overall health, and good eye health is essential for maintaining clear vision and preventing future vision problems. Regular eye exams can help detect early signs of eye conditions like glaucoma, cataracts, macular degeneration, allowing for prompt treatment and prevention of further vision loss. Good eye health is crucial for daily activities such as driving, reading, working on the computer, ensuring optimal performance and safety. Maintaining good eye health can also have a positive impact on overall well-being, as clear vision is important for engaging with the world and preserving one's quality of life. Tonight we will discuss good eye health and take viewer questions. Thank you for joining our discussion. This evening we are joined in the studio by Dr. Vance Thompson and Dr. Jed Assam. Both practice at Vance Thompson Vision in Sioux Falls, South Dakota. Welcome, and thank you gentlemen so much for joining us. Vance, tell us and tell our viewers a little bit about yourself and what led you to be an ophthalmologist.
Well, you know, my father was a family doctor, and where I grew up in small town South Dakota, actually the early part of my childhood in Lake Andes, and then we moved to Gregory, and where I went to high school, and it was amazing seeing his influence on the community and taking care of a lot of people, and you know, my mother was a homemaker there, and I went on to the University of South Dakota and went into, you know, medicine thinking I was going to be a small town doc like my dad. And my grandpa, you know, also was a small town doc in Watertown. But during USD medical school, spent time with an eye surgeon in Yankton, Dr. Wilcoxon, became fascinated with eye surgery and went on to do a residency. After my internship at Avera, I did a residency in ophthalmology at the University of Missouri Columbia, and then did a fellowship after that in Kansas City in refractive and cataract surgery, and then came back to the state I love, South Dakota, and have been practicing here for over 30 years. And so that's kind of my journey. Have a wife and 3 kids and 4 grandkids.
And we're lucky to have you both here in South Dakota and Sioux Falls. Jed, tell us a little bit about yourself and how ophthalmology called to you.
So for me, I've always very much enjoyed working with my hands. Being around surgery and getting to explore that field within medicine has always been a key piece of things for me. I started out in high school doing some volunteer work as a patient care assistant, anything to get close to helping patients and being closer to the OR and seeing that. As I moved through my undergraduate training, I went back to St. Paul, Minnesota, and was at Bethel University there, did training in biochemistry and chemistry, and then from there had a chance to go down to Omaha to get a master's degree training in clinical anatomy. And that was a really great spot to kind of hone dexterity and surgical skills and just kind of further reinforce that desire to be able to help people through being able to do surgery and help them see. And the ophthalmology portion, I would say, came more when I was in medical school at the University of South Dakota. You get to go through and see a diversity of specialties as you do your medical training, and ophthalmology was just a key spot that had a lot of fine-tuned dexterity and detail involved with it. I loved getting to see the joy on people's faces, and then which also is certainly rewarding as a physician to be able to get to truly see that as well. And that's kind of what solidified ophthalmology for me. My advanced training in ophthalmology was down at the University of Texas in Galveston, UTMB, and then from there I went and did further subspecialty training in vitreoretinal surgery at University of Texas in San Antonio, and now I've been back here working for the past year and a half at this point, so getting to provide for the community that I very much love and enjoy. So.
We were joking before the show that between the two of you, we've got the whole eye here, which is, for me as a primary care doctor, I don't often think about the idea that ophthalmologists have so many different specialties. Vance, how many specialties are there in ophthalmology?
Oh, there's, like 8 or 9. I mean, there's, a lot of subspecialties. So.
And it's amazing to think about how complex the eye is and how many different things can go wrong with it. Yeah. And what's really amazing to me as someone who started training a long time ago is how much it has changed in even that time frame. What you guys can do now is just amazing. So. Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about your eyes. And we've got the whole field covered here, so we can answer whatever, or at least try to answer whatever questions you have. Viewers can contact us in 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We'll work to answer as many of your questions as possible given the time available, but sometimes we receive more questions than we can cover, and we apologize if we don't get to your question. Your question will remain anonymous and no information is saved, but viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie. But it's not required to submit a question. The winner will be drawn and announced at the end of the program. And we've had some questions come in ahead of time with email and everything, so it's wonderful that our viewers are involved here. So let's get started. We have a question that came in from email earlier, and this is one that I field a lot as a primary care doctor. So my eyes are always watering during the winter months and even sometimes in the summer. What could be causing this? And this person says they don't have bad allergies. Jed, what do you have to say to this person?
So watery eyes, I mean, in terms of, we are in windy South Dakota, dryness of the eyes is certainly one of the things that most commonly affects people. It seems counterintuitive to tell somebody that feels like their eyes are wetter than they should be, that their eyes are dry, but the tear film, just like the eye itself, is a complex piece. It has multiple layers to it, multiple components that help to prevent evaporation, to make sure that the eye is protected. And if one of those layers is off, then you can still have dry eye. And so that, to me, would seem like one of the most likely potential causes. If you have predisposing conditions that can also make your eye drier, autoimmune conditions that basically cause inflammation in the body. Certain medications can also dry your eye out if you've been taking something like a decongestant or antihistamine. Those are things that can also cause dryness of the eye. While certainly a lot of people do come into my office and talk about not having allergies, it's always interesting as you kind of work through the story and the process as they've learned about their condition to kind of ferret out if there might actually be something that could be triggering it. And so I always probe deeply to see if there are triggers for things like that. So that is another piece that still, even though not probably the most considered for this person, might still be something to explore with their provider, beginning with their local eye doctor in their community, and then pressing further beyond for that.
So what other symptoms might somebody have that would indicate that maybe there were some allergies?
So other symptoms for allergies would be anytime you get exposed to a particular antigen, basically something that could cause inflammation, redness along the eyelid margin. You could also have the increased watering. Sometimes you can even get a little bit of thicker discharge and mucus with that as well. Things like dryness around the skin and the orbit of the eye are also things that can also be indicative of allergies.
Okay. itching.
Yep.
Yeah.
Congestion, generalized congestion are also pieces to that.
Yeah. Anything to add, Vance?
It's always, again, good idea to get that eye exam because everything that Dr. Assam just said is exactly right. A dry eye can actually water because it sends a message to your brain that the eye's irritated. And so it sends a message back to the tearing part that we call the lacrimal gland to try to flush that irritation. So people are surprised their dry eye can water. You also, can have the tear drain because we all have a drain on our lower lid and our upper lid. So the tears we make drain there, and that's why when you take a drop, sometimes you can taste it because they're draining onto our soft palate. And if that drain is blocked, eyes can water. And then sometimes people who rub their eyes a lot, we try to tell people don't rub your eyes and don't push your eye into a pillow at night because it can make your lids get, what we call lax. And that drain, it can actually turn out a little bit. And then when you blink, every time you blink, the tear can come down. So checking for dry eye, checking how your tear drains and your eyelid anatomy are part of that eye exam.
Very interesting. So I usually will tell people that, well, yes, your eye is dry because it's not making the right kind of moisture, so it makes those tears instead to substitute for it. And that seems to be more understandable about why my wet eyes are dry. So, all right, we have a question from Facebook. This individual spends a majority of their time each week working on the computer, and by the end of the day, and especially by the end of the week, their eyes are tired and sometimes their head feels heavy. Is there something I could be doing each week to reduce the strain and the ways my eyes feel so tired? Vance, what would you tell this person?
Well, this is something we hear a lot because our world has gotten so close. So many people are on their cell phone or they're on their computer. And normally we blink 12 to 15 times a minute. Blinking is really important to distribute the tears. A lot of people don't realize there's over 1,600 proteins in your tears. Your tears are, not only moisturizing, they're anti-inflammatory, they're anti-itch, they're anti-red. And so if you're not making a normal amount of tears, your eyes are going to become irritated. But also when you blink, they're distributing the tears just like a windshield wiper on your car. So when you go to read or look at your computer, your blink reflex goes from 12 to 15 times a minute, sometimes to 1 or 2 times. And so we'll hear this from gamers and people that are on their computer all day. They're just drying out because they're not blinking enough. So we say blink more and then rest your eyes every now and then by closing them and then sometimes having moisturizing drops by the computer. But hearing about irritated eyes like that is really common. And the other thing is, this gets a little complicated, but you've heard about the macula, and I'm sure we'll talk a little bit about macular degeneration, like what Dr. Assam takes care of. But when you look at something, you're looking at, it's with a perfectly straight line. We call it the line of sight. And if your 2 eyes line of sight, your most relaxed vision is at 20 feet. And now you're spending all day at 40 centimeters, and you're looking at that computer or your cell phone, your eyes are having to turn in and those muscles are working hard. And so for some people that can lead to eye strain. So taking a break, looking off into the distance, blinking more. And then in that eye exam, some people even need in their glasses little prisms that can help. Your local eye doctor can put you in those glasses that actually can help computer more comfortable. So lots of times just blinking more, taking breaks, and then seeing if there's anything to the eye strain. But it's very common and usually not a worrisome thing.
Just annoying.
Yeah, yep.
We have another question from email. This is a good one for you, Dr. Assam. My husband was recently diagnosed with diabetes. Should he be going to the eye doctor now more than once a year? And what are they looking for during those exams anyway?
Absolutely. So diabetes in the eye. Diabetes, as the way I describe it to people when I'm talking to them in my initial exam, is it's, as we all know, it's a condition with higher blood sugar and the way the body processes that sugar. Just like corrosion to pipes, that higher sugar can start to cause irritation to the blood vessel wall, and the eye has blood vessels as well as nerves in it. And so basically your electrical wiring plus your pipes that bring the blood in and out for nutrients. When those pipes start to get corroded with prolonged exposure to that higher sugar, you start to get leaking and fluid that can start to cause problems with your vision. The way I break down the systems that we learn in medical school and training is you kind of have a more reversible form of diabetes to the eye, where continuing to control your blood sugar, blood pressure can help to reverse some of these changes. And then for those that have had it longer or have had a very severe elevation of uncontrolled blood sugar for a period of time, you can get to an irreversible form of diabetes in the eye, where the eye is trying to repipe or put new vessels down to try to help return blood flow to certain areas, but unfortunately it can put them in the wrong place, and that can cause a lot of issues with scarring and more bleeding and vision loss. And it's really, to a degree, trying to monitor those that are in a more reversible stage and try to counsel and coach them to how to prevent those progressions to getting to an irreversible, where we do tend to have to intervene more with some of the therapies that we're very blessed to have at this point in time with the technology that's available that can help to preserve a lot of sight that before was lost a lot of times.
So how often should someone with diabetes have an eye exam?
So for just initial routine exam, if your provider has not seen anything concerning for immediate diabetic effects in the eye, typically I recommend an annual exam. The more findings that you have of that bleeding and leaking or fluid, sometimes we see people as often as every month to every 3 months to make sure that they're getting monitored well, so that we're helping to preserve and protect the sight that they have.
So the answer is very independent, or very dependent on the individual. But at least once a year, if you have diabetes, you should be seeing the eye doctor.
The importance of an initial screening exam if you have diabetes can't be overstated, and then from there having and helping to work with that provider so that they can get you to the care that's needed based on their expertise and what they're seeing. Primary care doctors out in the community are absolutely essential for this, and something that I would definitely encourage people to make use of.
Absolutely. I'm not going to do much about your eyes, but I'll help you get that blood sugar down so that your eyes are protected. And then Jed here will take care of the damage that's done. So
we all have a role to play in helping protect people.
That's right.
Absolutely.
This individual says that they have a family history of eye diseases, and what sort of precautions should this person take as they age? They're currently in their 40s, and should they be going in more frequently because of that family history? Vance?
Well, usually that once a year exam is important. You know, in your younger years, maybe every 2 years is okay, but once you get into your 40s, you really want every year. And one of the main things we're looking for is glaucoma, and that would be elevated pressure in the eye, because one of the problems with glaucoma, it can damage the nerve that takes vision from your eye to your brain. We call it the optic nerve. And if those nerve fibers get damaged, you don't get them back. And that's why you really want your eye pressure checked every year after the age of 40, just like you want your blood pressure checked every year after the age of 40. And then some of the other things, like macular degeneration, you might have that in your family. Having that retina looked at real good is important. Some people who are nearsighted, they have family members who have had retinal detachments. It's good to have an eye exam to make sure, that's not going on. But a good general exam can tell you if you have any of those things that kind of run in your family. It relieves people to also realize that just because it runs in your family doesn't mean you're going to get it. You know, lots of times the odds are still in your favor, but getting that eye exam and just making sure is really important. And it does help to tell your doctor your family history, to know your family history.
Perfect. Here's a question. They're thinking about talking with their doctor about LASIK. What kind of questions should I be asking, and are there patients that cannot get the surgery? Boy, what a perfect person to answer that question.
Yeah. No, LASIK is just a wonderful procedure for the right patient. And I always explain to patients that the main focusing element of the eye is the cornea. The front window in front of our pupil makes up 75 to 80% of the focus power of the eye just because of its curvature. And then behind the pupil we have the lens. The lens is where cataracts develop, but the front window is where LASIK happens. So if someone has 2 units of nearsightedness, that's enough to have a hard time seeing the big E without your glasses. And with LASIK, you can change the shape of the cornea so that it's the proper focusing power, and then a person doesn't need glasses. And so the real important thing with LASIK is to make sure that your cornea is nice and regular, gets back to the eye rubbing or pushing your eye into a pillow at night can make an irregular cornea, and then it's not safe to have LASIK. So we do what's called a topography. Just like you can look at the Earth's surface and tell what's a mountain and what's a plateau, we can tell those irregularities in the cornea. And so if the topography is nice and smooth and the cornea has the right thickness and the correction's not too high, then the patient's a good candidate for LASIK. But if their cornea is thin or irregular or the correction's too high, then we talk about either doing nothing, or there's other procedures like lens implants that help patients with high corrections in amazing ways. But I always recommend ask your local, eye care provider. They have a lot of, good knowledge about this. And then if you're ever interested, we do consultations all the time for people that, I've been daydreaming about LASIK. I just want to know if I'm a good candidate. So as I daydream, I know what my best options are, and I can really do some good research on my own.
Fabulous. Yeah. Bifocal glasses are a type of multifocal lens designed to correct vision at 2 different distances. Prairie Doc spoke with Dr. Ken Knutson from the Brookings Health System about when and why patients would need this type of prescription.
So there's different styles of bifocals and different options in how they work. For people who wear glasses, we can call a bifocal. Usually we'll use that term when you have a straight line across the lens on the lower part, and that gives you that extra power for the up close. A lot of people nowadays use a progressive bifocal, or a no-line bifocal is another term, where you don't see the line, it's ground into the lens, where it progressively gets stronger as you go down. So with a progressive bifocal, it kind of acts like a trifocal. You have your distance, and then there's an intermediate channel, and it slowly gets stronger for the up close. A lot of people choose that option nowadays.
Bifocals start to become necessary when individuals reach their 40s.
And so the actual name for the condition is called presbyopia, which in Greek means vision of old age. But it's more, kind of starts in our 40s, so not super old, more like middle age. So most people start to notice in their mid 40s-ish up to about 50. Even if you haven't had glasses for distance in the past, even those people will eventually need something to focus up close.
When getting bifocals, individuals usually adapt quickly, but there are some changes to get used to.
Most people adapt pretty quickly, but there are some changes that take a while to get used to. If you're getting a line, some people then kind of notice that line until their brain adjusts. They have their distance area to look through, and then the lower part. And so usually a week or 2 people adjust to that. With a progressive or no-line bifocal, It's somewhat more seamless, but usually within a couple of weeks, people can adjust. Once you get that fix, it makes life a lot easier for reading or people going to the restaurant to see the menus. Then they appreciate it.
Dr. Knutson always does such a good job, and bifocals are a fact of life for all of us eventually. So here's a good follow-up question about the LASIKs from earlier, because we've got a lot of questions coming in, which is wonderful. This individual wants to know, if they have the LASIK surgery, do they need glasses? And if not, would their vision ever get bad again?
So it's one of the reasons we don't do LASIK on 10-year-olds, because their eyes are changing a lot. And we would be able to take care of their correction at that moment in time, but they're going to continue to develop their nearsightedness. So one of the things we like is when the correction is more stable. When the correction that you're getting, any changes that when you're seeing your doctor, they're either teeny or no changes, and then we review that in your exam. And then as far as over time, most of the big changes, after you get into your 20s, aren't happening so much, and so that's typically when people become good candidates. Now, if they're getting ready to go into like professional school, and they're going to be doing a whole bunch of studying, sometimes you'll find that the nearsightedness progresses, and we'll say you might want to consider doing it after you get done with those intense studies. But typically, so the LASIK correction is permanent, but the internal eye still ages. And one of the things, just like Dr. Knutson just talked about, presbyopia, that lens behind your pupil that used to zoom in and read, starts to get stiff when we get into our 40s, and it won't zoom in. So whether you have LASIK or not, eventually you end up needing reading glasses. We actually have great treatments for that too, but LASIK is a permanent correction, but your internal eye can still change, so it's good to wait till the big changes have slowed down.
Fabulous. This is an individual who emails in to say that their child got hit in the face in physical education in gym class with a ball, and they went to see their eye doctor, and he said everything looked okay. It's been a few days, but the eye's still swollen. Should they go back to the doctor?
So injuries to the eye are always kind of a diverse mix of what you're going to get and how much trauma there is based on the initial injury. I would say if there is certainly concern, I always tell my patients I would like to see if there is a concern. So I would say to that individual, if there's still concern, I think it would be warranted to go in and take a look. It never hurts to see what's going on and be reassured that everything is healing normally. What's worse and more concerning is when I see somebody that waited too long, and then we have to tell them that they should have come in earlier. So I don't think that anybody's going to fault them at all for having a concern for their child and coming in to have a look at things.
Does a swollen eye, a swollen lid, does that automatically mean damage to the inside of the eye?
Not always. Fortunately, the eye and the body are very naturally protective of sensitive organs such as the eye, so sometimes just by the natural reflex, the eyelid will take most of the blunt of the trauma, and that fortunately is where the lid becomes more swollen and the eye can sometimes be more protected because of that.
Fabulous. Here's an individual who says, how is the surgery to deal with the heaviness that comes with droopy skin over the eyes? What is the risk, and is there a vision benefit? This individual says that the weight on their eyes makes them tired.
So there's actually great surgeries for that, and some people, when they're talking about eyelids, it can be cosmetic because they have maybe one that's drooping more than the other, or they're both drooping more than they want, or there's extra skin, and there's great treatments for that. But some people, it actually is something that can start to blur vision. Where a lot of people will notice it is they're at a stoplight, for instance, and they actually aren't really seeing the stoplight because their upper field of vision is being blocked by their droopy lid or too much skin. And so we can do a test where you actually tape up the eyelids and see what that does to the field of vision. And that's why insurance will often help them with surgeries to help when their vision is being obstructed. So it can be cosmetic, or it can be actually visually improving, or both.
Fabulous. Here's someone from Facebook who says they're in their 40s and they've noticed that they take their glasses off to read sometimes now, especially if it's smaller print. Do they need to think about bifocals? When they take their glasses on and off, sometimes their eyes have trouble adjusting back to the glasses quickly. Jed.
So this is kind of a very good description of a condition we call presbyopia, in which Dr. Knudsen actually kind of very nicely outlined in a commercial that we just had. So as the eye ages, the lens naturally starts to harden, and so our ability to look at something far away and then accommodate or look at something up close becomes impaired, and that's where vision correction through glasses or other means becomes a very important factor to being able to still utilize the valuable power of the eye to see, but you just need an aid to be able to compensate for what is being lost in the lens flexibility at this stage.
And it's just a natural part of
It
life.
is a
If you
natural
live
part of
long
life.
enough, you're going to need bifocals and you're going to get cataracts.
Yes.
Just the way it works.
I think that also about that particular person, some people that are born nearsighted, so they're blurry at a distance, but they're clear up close. When they have their glasses on to see the world, and they're getting into their 40s and their lens won't zoom in like it used to, they can take their glasses off and use their nearsightedness to read. Some people get sick of that on and off, so that's why they put bifocals in their glasses so they can do distance and near. But if you're the opposite, if you're farsighted, you actually are, taking your glasses off makes it worse. And so it depends on what your correction is. So that person is lucky they can take their glasses off and read. And there are great treatments for it, but it is a very frustrating thing that happens to everybody.
Yes, everybody. That sometimes is a little comforting.
Yeah.
So. Here's someone who emailed and said that they're not restricted on their driver's license, but lately after reading a book or being on the computer for an extended period of time, they have trouble focusing. This person's 74 though. Are their eyes just getting old and tired? That's a great question for the refraction expert.
Yeah. And so a lot of people don't realize that their tear film, right where the air meets their tear, is the most powerful focusing element of the eye. We call it the air-tear interface. So if you're staring a lot reading, or staring and looking at a computer, and your eyes are dry, you're getting dry spots on your front window, your cornea, just like driving in July or August in South Dakota and there's a lot of bugs on your windshield and it starts to rain, you're almost afraid to start that windshield wiper because you know it's going to be really blurry because the air-rain interface is so irregular. And once you get the bugs off and you get a good skim and the air-rain interface is smooth, you have smooth vision. Well, you need that smooth tear film for smooth vision. And so when we hear things like this, the first thing we're checking for is a dry eye and treating that and telling people to blink more.
I'm noticing a theme.
Yeah.
Fabulous.
I want them to be known as Colonel Blinkmore. I actually tell them that. So.
Now I'm thinking about blinking
Yeah.
all the time here. Refractive lens exchange is a surgical procedure similar to cataract surgery. It is often used to correct refractive errors such as severe nearsightedness, farsightedness, and astigmatism. Dr. Michael Eide and Dr. Andrea Bordewick, all right, are cornea disease specialists at Ophthalmology Limited. Together, they share their insight on this procedure.
So when it comes to LASIK, for example, we're focusing on the cornea. So we have the cornea, that's the clear window in the front of the eye. And then when we're talking about refractive lens exchange or cataract surgery for that matter, we're talking about the lens in the eye. So the lens sits behind our pupil, behind our iris, the colored part of the eye. And between the cornea and the lens, they help us focus light on the back of the eye.
LASIK is focused on the cornea. For the refractive lens exchange, the focus is on removing the natural lens in the eye and replacing it with a new lens.
LASIK and refractive lens exchange are both options when the eye just has a focusing issue, not necessarily any structural damage or any disease to it. So LASIK's typically more in younger patients, although you can do a refractive lens exchange in younger patients because they don't have any development of a cataract yet or any lens problems. Refractive lens exchange becomes more of an option when someone's not a LASIK candidate typically.
There's a wide array of intraocular lenses available and varies depending on the patient.
Recovery from refractive lens exchange and essentially cataract surgery for that matter is very quick. Everyone's a little bit different. Each eye, even on each individual, can be a little different because it's healing from a surgery. Where there's incisions, we expect there to be some swelling, and in the eye that can show up as some more glare, as blurry vision. So we anticipate that things will be pretty blurry, especially the first day. And then it really depends. The next day, there's some patients who don't have much swelling and they're already really enjoying some great vision, and that continues to improve over time. There's other patients where they have a little more swelling. A lot of them, most of that's gone by a week.
This has been such a great show so far, and we've had a lot of interest. So, gentlemen, we're going to play speed round here with lots to get to as many questions as we can. Here is someone who says they had cataract surgery a few years ago, and now they're experiencing a flashing during dark accommodation. Is that something for them to worry about, Jed?
So flashes can come from a number of different things, but ultimately, if it is something that's new and persistent, especially if it's accompanied by new other changes like floaters or spots in your vision, it's always a good idea to get that checked out. The biggest thing that we always worry about in the ophthalmology and eye world is there a tear in the retina that could result in a detachment or a loss of vision from that? And so it's better to go in earlier and be told that everything looks good rather than to wait too long and then start having vision changes, because what has to be done after that is much more involved when it can usually be fixed in the office, which is much better.
Absolutely. That's one of, as a primary care doctor, new flashers get me all excited. Yep. This individual says that they had cataract surgery a few years ago. Oh, no, sorry, that was the same one. This person says they have an eye twitch every now and then. Is that something that should concern them, Dr. Thompson?
So eye twitches can happen when people are tired or they're having stress, and the little muscle right under the skin spasms. And I tell patients that typically they go away over a 6 to 8 week period of time. Try to get some rest, try to reduce the stress, but if it continues, you can see your eye doctor, and there are things that you can do for persistent twitches like Botox or something like that.
And maybe you need glasses.
Yeah.
Maybe your eyes are tired. This individual says that they are scheduled to have their eyelashes lifted with their ophthalmologist. What's involved with that? Jed?
So eyelash or eyelid lifting involves basically there's a pulley system that helps to control the lid movement, and what they'll go in is make a small incision and then help to tighten that pulley system to be able to lift up what has become more lax or loose. Just like taking a rubber band and stretching it many, many times, it starts to lose its elasticity. The same thing can happen with the eyelid over time, and that plays into things like we've talked about as well, where eye rubbing and dryness of the eye, people can start to get looser, laxer lids just as a result of doing that. So trying to avoid that is also a good way to limit the amount of laxity in the lid.
We've got a couple questions here about macular degeneration, and I know that's something
That's
that you
my area.
specialize in. So this individual wants to know, what is wet macular degeneration, and is it okay to pause the shot treatments if they seem no longer effective? Another part to their question, is it common for macular degeneration to cure itself and not come back? And then we have a question about, is there anything to slow dry macular degeneration? So I'm going to start. What's the difference between wet and dry? What is macular degeneration, and what's the difference between wet and dry?
Nope, that's a very good question, and these are questions I get from a lot of people in my clinic daily. So macular degeneration is a condition that typically starts presenting with people in their, sometimes as early as 60, the average is probably 70s and 80s, though, that we start to see most of this. We've given it two names of wet and dry to describe separate states of the condition, but the important part that I tell people when I'm talking to them initially is that these two conditions can actually occur together because they affect different parts of the eye. Even though it seems counterintuitive to have wet with dry, they're actually both progressing. And then the next question that's most commonly asked is, well, which one is worse to have? Well, they're both going to be progressive, and they both can take away sight over time. One just moves faster than the other. Dry, which is what around 80 to 90% of people with macular degeneration have, is one that moves slowly over many, many years. Wet, on the other hand, is one that can move and start taking vision away over a matter of weeks to months. And fortunately, for at least the last 30 years at this point, we've had medications that can help reduce or certainly slow down and sometimes even stop and stabilize the wet macular degeneration process through injections, which is what was asked in the question. And those injections have been just truly field changing since they've been around. Before, when there was no injections, people would lose vision very rapidly, and it was just a matter of counseling about that process. The wet injections, the important part though for people to understand is there are cases where if you get the wet caught early enough, we can oftentimes sustain your vision for much longer. But it's important to always remember that even though the wet is stabilized, the dry is still progressing, and eventually it does start taking away vision from that. And so in terms of, is it still a good idea to continue the injections? The studies and literature and people looking over many, many years of data have shown that continuing the injections in the present state of technology still is the best thing, because wet macular degeneration can come back over time, and when it comes back, it is something that can be devastating because you can get abnormal vessels and bleeding under the retina, which, just like having too much of a good thing, blood outside of the vessels in the retina can be toxic, and it can take away vision that we then can't get back. So it's that ever-present balance of knowing that wet and dry coexist, even though they're called different things. They are affecting different parts of the eye, and stabilizing one doesn't mean that the other one isn't continuing to progress. Historically, we have not had anything in the past that has been able to totally stop or reverse dry macular degeneration. Within the last 2 years, there are some new technologies and medication that do allow us to inject a medicine that can slow it down. The way I describe it to people is, it's kind of like going from 100 miles an hour down to 75. The macular degeneration, or you are still moving forward, but we're moving forward slower, which has been certainly an add to the field in the recent last couple of years. So from that standpoint, we do have things that can slow it down a little bit, but ultimately it's not going to totally reverse the dry macular degeneration either. The exciting part about being in the field of retina and getting the opportunity to go to meetings and talk with peers in different parts of the country and around the world is that you have so many new neat technologies that are just over the horizon at this point in time, probably within a few years away, where we might be transplanting new cells under the retina, We might be utilizing nanotechnology to be able to restore some areas that are lost currently by dry macular degeneration. But as it presently stands, the biggest things are maintaining screening if you are diagnosed with dry macular degeneration, if you have wet, making sure you are continuing to follow closely with the eye doctor that's giving you those treatments, and kind of following their guidance on where you should be getting those injections and how often. And then with the dry, further kind of exploring those options with your eye doctor if they think that you're a good candidate for some of the dry treatments that are out there.
That's a question that I think is down here later about, well, why don't we do injections for dry? And I'm hearing you say the injections we use for wet are different. They don't help the dry because it's different diseases. But in this exciting time, we have some new treatments for dry, and maybe in the next few years we'll have even better treatments for dry.
That's absolutely correct.
I learned something today. Here we have someone who says, have you heard or do you know anything about eye mites?
Yes. So, we have these little mites that actually live in our skin and in our eyelids. And the most common one is called Demodex. And it's something that if too many of them start to be in your eyelids, they can cause redness, irritation, itching, and dry eyes. And there's great treatments. There have been good treatments for many years, but there was just FDA approved not that long ago. And we had the honor of being in the clinical trial to help get that technology FDA approved to treat eye mites. And so if you have red itchy eyes, it should be something your doctor's looking for.
Fabulous. Here's someone who says, can you give some information on eye problems that can happen for a person who has Parkinson's?
Well, one of the things that happens with Parkinson's is that same blink reflex starts to reduce, and they can develop what's even called a Parkinson's stare. And so what we do in Parkinson's is we make sure to treat their tear film, because that tear film is not only important for vision, it's important for eye health, and there's great treatments. And then to try to get them to blink more, and sometimes that means your loved ones, telling you and reminding you to gently close your eyes, take a rest, but there's great things we can do for that.
Fabulous. Parkinson's is a difficult disease. Here's someone who says that they were diagnosed with central serous CR. Can this be controlled or eliminated? First off, that's something I hadn't heard of, but that's something that you treat. So tell us about that.
Yes, absolutely. So central serous retinopathy, or CSR, is a condition where a layer just underneath the retina starts to get leaky. So normally this layer basically creates a negative pressure, a suction, if you will, of the retina to the back of the eye. And different things, typically an elevated cortisol level or stress hormone in the body, can cause this kind of reduction in that layer's efficiency of keeping that suction there. As a result, people can start to develop fluid. The most common people that this develops in are typically type A personalities, more commonly males, typically in their 20s to 40s. And other things can also cause its progression, things like not getting enough sleep, overconsumption of caffeine. If you're a very heavy coffee drinker, that can also do it. Getting steroids in the body, whether they're inhaled through an inhaler or intranasal steroids, injections that are given for knee joints or other things, oral steroids, these are all things that can also cause this as it adds or elevates that cortisol or stress hormone level to a degree. And so these are questions that I'll ask and things that I'll assess with the patient. Fortunately, in the majority of these cases, it's reassuring to know that it will self-resolve typically, especially with getting better sleep, reducing caffeine intake, whether it's energy drinks, coffee, sodas, and then just trying to find ways to reduce stress. Everybody finds a different way to do that. Yoga, meditation, just finding time to breakaway and recollect is always a good way to try to reduce that as well. So there are a select few cases that can be more progressive, and that's where following up with your local eye doctor to make sure that the condition is appropriately resolving as it should, and that they're helping to counsel and coach you on the process of those things that you need to be doing to help resolve that.
Fabulous. Here is an individual who says that they've got floaters on the eye, and they have been noticing many floaters on both eyes for the last 2 weeks. What do you recommend for care, Dr. Thompson?
Well, I recommend that they see the retina specialist because that is the area of the eye we call the vitreous, and we all get these floaters, and the majority of them don't need to be treated. The majority of them either we get used to or they settle out with time. I like to use the analogy of a snow globe. You shake it up, but with time they can settle out. But for the ones that can't, I send them to the retina specialist. Mm-hmm.
And sometimes those floaters are a sign of something far more serious, so that needs to be checked out.
Yes, that is true.
New floaters need to be checked out. Go see your eye doctor. Here we're just about out of time. Here's someone who says they had cataract surgery 3 years ago and the nearsighted vision is getting worse. Is there anything that could help with this, Dr. Thompson?
Yeah, so in cataract surgery, you have a choice to do a traditional implant where you wear bifocals with it, or you can do an advanced implant where the bifocals are built into the implant, so you don't need bifocals. So that's one of the big decisions. But let's say they had a traditional implant cataract surgery and they're into bifocals. It might be that their bifocal isn't strong enough, so they should have that checked, get their glasses checked. But sometimes it's also another thing going on like dryness, or the cataract is like a grape and a grape skin. We take off the front of the grape to get to the cataract, take out the cataract, leave the back grape skin, put the implant in, and the back grape skin can get hazy, and sometimes a very short laser treatment takes care of that.
So, bottom line, go see your eye doctor. Yes. And that's all the time we have tonight. This has just flown by. Our winner is Sue. A book will be sent to you shortly, and we'll be back after this.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
Thank you to our guests, Dr. Thompson and Dr. Assam, for volunteering their time to help us learn more about the health and wellness of your eyes. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online, and listen to us on Prairie Doc Radio on South Dakota Public Broadcasting Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science and built on trust. Until next time, stay healthy out there, people.
A regular heart rhythm is essential to your health. It ensures your heart delivers the necessary nutrients and oxygenated blood to the tissues, organs, and cells throughout your body. Rhythms of your heart, next time on Call with the Prairie Doc.
Hi, my name is Joni Holm, and I serve on the Healing Words Foundation Board, the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,